Okay, so hello everyone. I am Ahmed Al-Barki. I'm a VR surgeon at Sheikh Khalifa Medical City in Abu Dhabi, UAE, and I'm an assistant professor of ophthalmology in Bana University in Egypt. It's a pleasure for me today to share with you our experience in UAE with fluorescein actinide implant in DME. I'm going to share with you uh, 2 years data using Illuvin in DME. Um, Before we start, I just want to highlight that recently we managed to publish our first publication about Illuvin in the Middle East in Clinical Ophthalmology Journal, and it was rapid structure and functional improvements with Illuvin in DME 6-month data. And as you see, in 6 months, for sure, it's a short period of time in terms of talking about a drug that lasts for 3 or 5 years. But in this study, our main objective actually to look at the rapid and the fast effects in terms of structure and functional improvement. Because when we start for the first time to use Illuvin, we found that some patient that, or most of the patient improved, and the improvement happened very quickly, as we're going to show that. So I'm going to share with you highlighting these studies that we published, and then I'm going to share the 2 years data. So in this study, we look at I told you the rapid structural and functional improvement. In this study, we include 22 patients with DME, pseudophakic patients. So all the patient with phakic was excluded. Treated them with Illuvin, and the patient was monitored at month 1 and 3 and 6 months at the beginning. And we use the following, or the usual parameter, that's best corrected visual acuity from ETDRS letters and central macular thickness, and for sure the IOP control. If you look at the result, this is first the characteristic or demography of the patient. You can see here, the one I want highlighted here is the duration of DME, because some of the patients, the duration was 6 to 12 months, so it was early compared to the other study, which was starting using steroid after 2 years or more. So I think this has an impact on the result at the end. So all the patients received before a dexamethasone implant. For sure, they have history of anti-VEGF. Some patient has laser, and 10% of the patient has been vitrectomy before. This is the summary of the demography of those patients. Look at the result. The visual acuity gain, actually, it was interesting, a huge visual gain improvement from one month, 3 and 6 months. And if you look here, you can see at 1 month, the improvement in visual gain was very high and very quick also, and it was maintained until 6 months. If you look at the subgroup analysis of those patients, we look at how many patients improved for more than 5 letters, 10 letters, and 15 letters. And you still can see here in 1 month, for example, we have 17 patients that received improved by 5 letters. And if you look at 6 months, we have many patients that improved by more than 15 letters. What about the central macular thickness? Actually, the improving or the reduction in central macular thickness was mirroring actually the visual gain. So we can see here a very rapid drying effect at month 1, which continued to month 3 and then until month 3. So there was gradual improvement or continuous improvement, but was a fast effect at 1 month. And let me tell you something, in some patients, we see some improvement after only 2 weeks after injection of fluorescein actinide implant. This is just subgroup also to show you how many patients resolved in terms of microns, like 50 microns reduction, or 100 or 150 and 350. And you can see here again, if you look at month 1 in a dark color, you can see that in month 1, we have some patient that reduction of 150. And for sure, at 6 months, we receive some patient who improved by 350 micron. Again, I believe the result, we should consider that the early treatment, the early usage of the treatment, just a general rule, by the way, if you treat early, definitely you get a better response. What about IOP? IOP, we have 3 patients who has rise of IOP, but was controlled by medication. And this percentage matching with the other study, in terms of IOP rise. And as I said, all the IOP patient or the IOP rise was managed properly with IOP lowering drops for the 6 months. This is just to conclude all the data in one graph, the yellow for the visual acuity and the blue or purple for the central macular thickness and IOP in red color. Now I'm going to share with you now this, as I told you, this was 6 month data only, has been published. Now we are this data, which is effectiveness and tolerability of the fluorescein implant for 2 years durations, is now under review in Retina Journal. Hopefully we get feedback soon. So let's share with you what happened after 6 months. The journey continues with those patients, and we keep follow up them and teach you to show the effectiveness and tolerability of the drug. Again, just to remind you about the study, the methods. Again, we have 22 patients, DME pseudophakic, and we keep continuing this patient until 24 months. This is demography. So let's start with visual outcome. As you can see here, in the first year, the gain was more than 15 letters, and this gain was maintained or kept for the 1 year extension or until the end of the study, 24 months. We have some 5 patients who require top-up with anti-VEGF after initial gain during the study. And we have 1 patient who get additional 3 lines in year 2 and 2 patients additional 1 line in year 2. And 17 patients maintained the visual gain for the whole follow-up period. What about the central macular thickness or anatomical outcome? It was again reflecting or mirroring the gain in the visual acuity. And also this gain was maintained, or so this reduction or this effect was maintained, or the drying effect was continuous until 24 months. Just let's combine 2 together, the visual acuity with central macular thickness. You can see here it's like crossing, so it was mirroring each other. And this is the IOP. I just want to add something here that 1 patient needs glaucoma surgery, Ahmed valve, because it was not controlled of the intraocular pressure. Initially, it was controlled, but then it needs to pressure start to rise up again, and we need at the end to do glaucoma surgery for this patient. And by the way, the patient now is dry macula, visual acuity is improved, and the pressure is also controlled. So in conclusion, we found that fluorescein implants lead to rapid and sustained improvement of visual acuity and decreased central macular thickness. As I told you before, we see the onset of the effects was seen some patient 2 weeks, and most of the patient was after 4 weeks after injection. And all patients experienced 3 or more lines improvement of visual acuity and was maintained for 2 years. 90% also of this patient maintained sustained drying effect of the macula at 24 months. So the results was interesting, and I believe in discussion for this study, I mean, one of the main effects to find this data, I believe the early start of the treatment. So let's now share some cases or some stories. I used to do that because it reflects real scenario in our real practice. So because, you know, in our real clinical life, sometimes or most of the time, actually, it's not the same like in clinical trial. So I will start with the first patient and or first story. I saw that non-compliant patient, and we in our area specifically, we are seeing there is a certain percentage of patient that is non-compliant. And despite the fact you explain for them everything and the value of the treatment and this, how important to stick to your injection. So let's see the first case, and this was included in the trial. This is a female patient, 54 years old, poorly controlled type 2 diabetes. And for those my colleagues in my area in Middle East, we have this problem that most of the diabetic patients are not controlled because of the obesity and sedentary lifestyle and a lot of stuff. So usually it's very uncommon to find a patient who's controlled blood sugar. Visual acuity was dropped in the right eye, 2100, And you can see here in the OCT this cystoid macular edema. So as most of the patients, we start with anti-VEGF injection, and for sure, explain the patient that we need monthly injection until stabilizing and maintaining the gain, and then we can either treat and extend or PRN, whatever. So despite we already instruct the patient about the importance of sticking or being compliant to the injection or the visits, and we started injecting him. After 2 monthly injection, actually the result was amazing and the visual acuity improved. And he's scheduled for the third one, but unfortunately the patient didn't show until 4 months later. And expected for sure the macular edema recur again, which was more than at the presentation and worse visual acuity when he came the first time. So again, we explained for him the importance and the value of to get the injection on time, not to miss anyone. And we started again anti-VEGF, the same anti-VEGF I used. And after 1 month, you can see here it's a very good response. So this patient is very good responder in terms of response to anti-VEGF. But the issue here again, he didn't show up for another 3 months. So again, macular edema recur. And if you look every time the macular edema recur, the visual acuity is worse compared to the first time. So this is very important to avoid fluctuation of the macular edema. It's better to have a dry macula as much as you can, as long as you can. Another anti-VEGF, because you said it's controlled, it's responding, but the problem is it's only compliant. So each time I'm trying to push the patient and explain for him, but this is some of the patient we have to face in the reality. 1 month again, very good response. But again, she didn't show. And you see here again, if you remember, every time the edema recur, it's worse in terms of the amount of edema and also in terms of the visual acuity. So now the vision is 2400. So this time I changed my plan. I said the patient, we have to choose something that stay in your eyes longer period of time, since you are not able to be compliant enough with the treatment. So I switched him to intravitreal dexamethasone implant. And after 2 months post-injection, it's very good results. Dry macula, except for some starting of macular buckling there, but vision is improved, patient is happy, everything is fine. 4 months later, again, recurrent edema was 2400. So for this patient, I explained with the patient that really we need, since we tried a steroid and you're not a steroid responder, so let's go for something that's stay in the eye for longer time. So we don't need to come every month or every 2 months or every 3 months. We can just have every 4 months, like for follow-up and to check. So I switched him to intravitreal fluorosilane implant, and 2 weeks, as I told you, you can see here like 50% improvement, visual acuity improved, and 4 months, you can see how beautifully dry, and 12 months post-injection, vision is good, dry macula, and 2 years still dry, vision improved, and except for the macular buckling here, and this is the maximum we can get, because if you look at the photoreceptor layer and the ellipsoid zone, it's disturbed because I think from the recurrent edema. So this is the first story, and it shows us sometimes you need to change your treatment according to the patient. Story 2, it was more easy for me and more easy for the patient. I name it easy decision. If you look at the history of this patient, 66 years old female patient, again, poorly controlled as usual. She came to my clinic as a second opinion because she received multiple intravitreal injection of anti-VEGF, almost 7 injections for the last 12 months, including intravitreal dexamethasone implant, 2 injections, and the last one was done 6 months before she came to me. And when I do the OCT for her, I found this cystoid macular edema was 2400, IOP is 15, means that after 2 injections of dexamethasone implant, the pressure did not go up. And by history, we asked the patient, did you use any anti-glaucoma medication? She denied that. So she's not a steroid responder, received twice injection of dexamethasone implant. And for sure, the reason the first physician who switched her to dexamethasone, I think I assumed that there was not good or enough response from the anti-VEGF. So it came in this case, so it was easy to make the decision. So I discussed with her about we can use the intravitreal fluorosilane acetonide implant, and we did that. And you look after 3 weeks post-injection, improvement of the edema, and 3 months post injection, 6 months, 9 months, 12 months, and 27 months. This is the longest, the patient has longest duration of the follow-up. And if you look here, the vision akid is not improved a lot, because if you look here, also again the thin retina and the atrophic photoreceptor layers was disturbed in the ellipsoid zone. But the patient is happy, vision is okay, and dry macula for 27 months. It was nice result. And let me tell you something about this case before the third story, that this patient, as I told you, she received already twice a dexamethasone implant, and there was no rise in the IOP. But as I mentioned in my study, that one patient needs glaucoma surgery, and this was the patient. So it was interesting for me that she didn't develop any IOP rise with dexamethasone implant, and when injected Iluvien at the beginning, she didn't develop any IOP, and after 6 months, it was developing pressure again, and it was not controlled until we do the glaucoma surgery, Ahmed valve. When I discussed this with our glaucoma consultant, yes, there is, steroid responder for sure, but I think it's not yet clear that, or not yet 100% sure that if the patient does not develop IOP rise after certain molecule or certain drug of steroid family, it's not guaranteed 100% that this patient will not have glaucoma in the future. So this should be considered in our practice. That's what I've learned from this case. But at the end, again, the patient did glaucoma surgery, vision is improved, stable, dry macula, and pressure is normal. So this not will stop me for using steroid, because sometimes you have to do that, and glaucoma surgery, it's now can control the IOP and the patient with dry macula, rather than keep the macula edematous, and which might lead to permanent visual loss at the end. Okay, story 3, this is an example of what we call it individualized treatment. Let's see the story of this patient. So he's a male patient, 69 years old, DME for 20 years, again, uncontrolled, a lot of comorbidity, but the most common is cardiac and hypertension. He has a history of stroke, which is very important, 1 month ago only, and he's still suffering from the stroke in terms of hemiplegia, coming to me wheelchair, on ambulance from outside the city, 3-hour drive with his son, complaint decreased vision in both eyes. So an examination of this patient, visual acuity 2400 in both eyes, pressure was okay, he has a dense cataract in both eyes. Do OCT, you can see here the cystoid macular edema, right eye and left eye with a lot of hard exudate. Just this is one video of one eye of the OCT, just a scan to show you how big the edema and also the dense of hard exudate. So if you want to treat this patient, what's the plan? Again, we have the tool in our hand, either to go for intravitreal injection of anti-VEGF or steroids as a first line. So what make me against anti-VEGF is the reason stroke, it's only 1 month, and also patient condition. He cannot come to my clinic monthly visit because of his general condition being hemiplegic and far away. So my decision was discussion of the patient that we will go for intravitreal dexamethasone implant. And I asked him to keep watch the IOP at home city, just to make sure that no need to come to my clinic to measure the IOP, and to come back to me after 3 months to check the result. So for sure, because of his general condition, he cannot came on time. He came 6 months later, not 3 months. And if you look OCT again, you can see here the macular edema. I think it's either recurred or not resolved from the beginning. But according to the history, the son claimed that his father, after injection, after 1 month, he started to see better, and this recur again. So it seemed that the dexamethasone implant worked, but as you know, that it does not last in the eye more than 4 months in our hands. This is the right eye, and I want to highlight also here the hyperreflective dots here, which could be, as you know, it's well known that it could be considered now a sign of inflammation. And this is the left eye. We can only have one scan also because of the density of the cataract, and the vision again the same. So the plan, pressure was not rise, so it was good. It's not a steroid responder. Again, it's not guaranteed 100%, but it give you the channel, the give you you'll be secure if you use a steroid in this patient. So what's the plan now? So I discussed with the patient that we need to go for combined FIC. We need to remove the cataract because it's very dense, and we inject intravitreal phenolphthalein implant because we need something that lasts long in the eye. And at that time, we have some experience with Iluvien. So I offer for them this plan, was agreed, and we did really a combined FIC complication with intravitreal phenolphthalein implant. So 1 month later, you can see here very nice result. Again, have a look on the hyperreflective dots here. Vision improved a lot, and you can see even the we can have clear image of the OCT because of the cataract removal. And this is in the left eye. This 1 month. Pressure, thank God, does not improve, does not rise. No need for any medication. 9 months later, you can see more dryness and in both eyes. See here, and story 4. I call this patient was not included in the study because she was phakic, but I will share you why I name it. You will know after I discuss the patient why I name it the mystery. So this patient, this is my last patient, my last case to show. It was female, 55 years old, type 2, again, uncontrolled as usual, decreased vision in the right eye 2 months ago. Examination, visual acuity was 20/50 in the right eye, 20/20 in the left eye, pressure is okay, almost clear lens. OCT showed that cystoid macular edema was leak cyst in the center of the in the fovea. So as we start as usual with the phakic patients. So we start with anti-VEGF. So I start with ranibizumab after 3 consecutive monthly injection. And by the way, this patient was very compliant. I should add the title mystery in compliant patient because very compliant patient. She came on time every month. After 3 consecutive monthly injection, no change in visual acuity. And if you look at the OCT, exactly the same. Maybe some change in the reflectivity of the fluid inside the cyst, but still exactly the same in terms of size and visual acuity. So I am the one who usually start to switch early, especially in those cases with no response at all after 3 monthly injection. I discussed with the patient that we can use a steroid, but it has a risk of IOP, or shift to another anti-VEGF, which I don't do nowadays, again, because there is no study or randomized control trial show that any benefit from switching among anti-VEGF in DME, especially talking about. So I switched to aflibercept, as again, after discussing with the patient, and for 3 consecutive monthly injection, still visual acuity the same, OCT the same, almost the same. So after 6 monthly injection of 2 different anti-VEGF, there is no response. In those cases, usually in those patients, I like to investigate more because maybe something behind or something mysterious there, I need to clarify it. So I do FFA for this patient to check how's going on, what's going on, what's there. Is there something behind that or not? If you look at the, this is the early phase video showing the fluorescein angiography of the right eye. You can see here just a very small microaneurysm here and there, nothing more than that. And this is more angiogram going on more time. You can see here only small microaneurysm, nothing there, no sign of inflammation or vasculitis or whatever. And if you look at the picture of the consequence of the FFA picture, you can see this is the early phase. You can see a leaking microaneurysm, still leaking more, and then in the late phase, we can see here. So it's a typical case of a focal edema with leaking microaneurysm. So what to do now? I discussed with the patient that we need to switch to another molecule, despite the fact you are phakic, and we have the risk of patient for counsel for sure for the cataract and IOP, but the patient decide not to take the treatment and to defer it since the vision is not worsened, it's the same vision. And I totally agree with the patient. If you put yourself in his place, you receive 6 monthly injection with no improvement. So I will be hesitant to take any medication. So I will discuss, we agreed that, okay, let's wait and let's continue follow-up. So she came back to me after 3 months, but with decreased visual acuity compared to that. So if you OCT done, you look here, the edema actually is increased more than, and the visual acuity dropped more than 2050 now become 2000. So I think, sorry. So the plan now, I open the discussion again about the intravenous dexamethasone implant because we have nothing to do. We need, maybe the inflammation are there. That's why the anti-VEGF is not working properly. And if you look at the risk-benefit value, I discussed with the patient we have risk of cataract, but in your age, you might have cataract at any time. And the IOP rise, it's not glaucoma. If happen, we can control by medication. So after patient counseling, agreed for the treatment. So we give her intravitreal dexamethasone. But unfortunately, if you look here, after 1 month, the edema does not improve and the visual acuity was not improved. So I said, let's wait another, because dexamethasone it lasts for 3 to 4 months. Okay, let's say wait another 3 months. So after 3 months, the same. But after 6 months, you can see here, the edema become more. So, and IOP does not rise, that's good. So what to do now? Again, we discussed with the patient that we tried everything except for a new molecule at that time. It's a steroid by long acting. There is a chance to be improvement, but this is the only weapon in our hand right now because we tried everything. Again, we discussed with the patient either to re-inject again the dexamethasone implant, which I don't agree because there's no improvement at all. And risk of cataract in this case now it's very high, like 80%. So we need to know that cataract will be there. And also I discussed with her the risk of IOP. Remember, I learned the lesson from the case that she received Zordex and does not develop IOP rise, and with Oluvin that happened. So now again, I put it in the consent, and I used to cancel the patient against this. So after all this discussion, patient agreed for the treatment because the visual acuity dropped more than before. So we give her intravitreal phenytoin implants, and interestingly, after 1 month, the macular edema resolved, and the 3 month visual acuity improved. No rise in IOP, thanks God. It was very good result. So the only drug that's worked in this case is the phenytoin implant. But 9 month post injection, again, start to cataract for sure developed. You can see the poor quality of the OCT picture, and the edema is start to recur. Vision a little bit dropped, and IOP was not rising, so there is no steroid response. But now, what to do next? So we're still thinking about what to do. We for sure will do the cataract, and this is open discussion. I like. It will be a pleasure to hear from you what you're going to do in this case in your practice. So to take home message, what I want to highlight here, the first point that we are not curing the disease. I mean, we are not curing DME. DME is just complication of the diabetes, which is the enemy sitting there behind the scene. We are just treating the consequences of this disease. So this is one of the challenge that might lead to in our practice in different response pattern among the patients. So we have to put in mind, sometimes we need only to control it, not to cure it. Another point, which I've learned from the last case, there is something still missing in the pathogenesis because, in our practice, if the pathogenesis is still not well understood, because if there's only anti-VEGF or inflammation are there, all the patient will respond to anti-VEGF or steroid. But what we are seeing in our practice, still some patients does not respond, as I show you in the last case. And if you look at the new drugs coming in the pipelines nowadays, they are now trying to target not only the overexpressed VEGF or inflammation there, or inflammatory mediator inside the vitreous. Now they want to go deeply and targeting the endothelial cells. So what we are doing now, we are just targeting the overexpressed either VEGF or inflammatory mediators. So we call it extracellular VEGF or inflammatory mediator pathway. So we need to, I think the new drugs now coming, they are trying to target at the cellular level. So they target the cells to before overexpression of the VEGF of inflammatory mediator. So I think by that time, we can find a lot of result, and the pathogenesis will be more clear for us. The last thing I want to add here is one size does not fit all. I believe that all of you should agree with me on this, that there is no magic drug or pharmacotherapy to treat the DME. It should be a combination. Sometimes you have to choose your proper weapon on the proper time at early stage to avoid permanent visual loss, also to achieve an early gain and maintain result for your patient. And this is the end of my presentation, and I thank you all, and please stay home and stay safe. For sure, stay home, not for the physician, everyone except the doctors, because you cannot stay home. So I wish you all the best, and I'm really happy to get any questions. I will be happy to answer, and take care and stay safe. Thank you so much.